Jennifer, you're doing great. Thank you for presenting this. This is creating a bit of discussion. So we're just going to start from the top here in case people are just listening in instead of reading the comments. So there's a question from Stuart Demardas. I'm sorry if I'm missing the name. You're welcome to speak as well, please.
Yeah, I was wondering, but I think I already got an answer. If other, I think, yeah, if other reasons for osteoporosis were ruled out. Because, yeah, I agree, it's a high incidence for osteopenia or osteoporosis, especially in this young age group. But just to get a clearer view of what we're looking at.
Sorry, I think it broke up just a little bit, but whether other causes were ruled out in the patients.
Yes, that was my question.
Oh, okay. So we didn't, specifically evaluate, other than that one, the patient with quite severe decreased these scores than would be expected. We didn't, take that into account. But to my knowledge, I guess that's another factor to look at, definitely, that we have not done yet.
And Jennifer, as a follow-up to that, you had one person with a clinical reason to test, but the other people have said surveillance. So what was the indication for the surveillance?
So yes, the group had started doing testing, in general for patients starting in 2019 of all VEDS patients as a baseline evaluation. So it was more surveillance that way, just, kind of a baseline.
And I can comment on that, Shireen. We had 2 people in a row come in with quite low bone density that had negative workups. Those 2 people were worked up. And then I talked to Nasli, who did the prior unpublished work, and it was really common in her cohort. And then we asked Rachel, who asked the Facebook group, and a lot of people came back and said, yes, I have low bone density. So based on that, we just started doing it routinely in 2019, at least a baseline study with the indication that it was abnormal to repeat it.
That's great, thank you. Xavier has a question next.
Yeah, thank you for your talk. I was wondering if you had the opportunity to analyze some women, especially adult women, and if you had some kind of results.
Oh, Jen, I think you're cutting out again.
I know. Sorry, my head is really unstable. I think.
That's okay. I can answer it. Our cohort's really young, Xavier, so we did not look at any older women. All of our patients were pretty young, but of course, that's an extremely relevant point, and probably even more relevant than our young population.
I don't think that the clinical point of view, it doesn't seem to be a problem in women more than 50 years of age with VEDS. We don't see often fractures. So I don't know how they compensate that.
Yeah, I don't know either. And I think I've talked with our bone team a lot here, our like osteogenesis imperfecta, Dr. Lee. And I think the reason we're sort of looking now is there a way we can protect them later in life if this is a risk? And, some people weren't living as long as they are now. So do we need to address their bone health at this early age that we're seeing these abnormalities with vitamin D and calcium, and perhaps introduce weight bearing, as was brought up this morning, instead of, avoiding it, and so to protect long-term bone health.
Yeah.
Just as a comment, one of the ways to get more information about the mothers and the fathers in this situation is actually to do family studies. And the family studies may give you also more information about whether you have a familial, there's something else familial involved that is determining bone density. But one of the things about presenting the data would be, it sometimes is helpful to actually have the individual data points there. You're really looking at a shift in the distribution, which you can sometimes see better that way. And the sample, -2 is still within the normal range that you're looking at. And you're really just saying that, you're shifting this down and asking whether that has clinical significance in children and then in others.
Hal had a question as well.
Yeah, so I was wondering if you try to better understand mechanism, if you had looked at markers of bone formation and bone resorption, circulating markers. And also, you know, in line with Peter's comment that this is a shift downward, but largely within the normal range, I wonder if you had looked at potential nutritional relationships or vitamin D levels routinely checked. That's a really common problem in Loeys-Dietz syndrome kids to have low vitamin D levels, which is both nutritional and probably related to physical activity and sun exposure. But I'm wondering if you've tried to find other correlates with the folks that are at the low end of the distribution.
And,
Right, I think that's a good point because throughout the literature, I know it's you know that they have evaluated different bone markers, particularly more with just EDS and not VEDS in particular. But you know we haven't evaluated that necessarily, you know, in this study. But I know that has been considered, you know, in other literature, and it's a valid point, you know, that if also they're started on vitamin D, perhaps that was a factor in it.
And one thing, how, so we definitely, this is retrospective, we definitely going forward in a prospective fashion, that's, we want to include those markers of bone formation and bone resorption. We have been getting vitamin D levels with all of these, and only one of them had an abnormal vitamin D level. All the rest were normal. So it didn't seem related to vitamin D.
And is the bone density distribution different in Hispanics as opposed to whites in the area?
These are race matched. So I believe that including Hispanic ethnicity matched. So that should be adjusted for that.
Tristan had a question as well. It's generating a lot of good discussion. Tristan, can you go ahead?
Yeah, thank you. My connection is not probably good.
I can read your
was
question.
also about the fact that, sorry, the question was also about the fact that we don't see as much hip fracture or vertebrae compression in these patients. So could we question if the Z score can be used in this population? Z score is based on age, adjusted on age, but we know that these patients have maybe a lower weight and a lower height. So could you have absolute evaluation of the osteodensity assessment or something that is not adjusted on age, weight, and height?
Right, and that is a consideration that we've talked about, is whether height is included. And there's different types of DEXA scans, you know, which is what we've discovered. So certain, you know, genetic DEXA scans, you know, take into account the height in the assessment. But I think that it's a very good point that whether, you know, in general, even for pediatric patients, they won't say it's osteoporosis unless they have clinically, you know, significant fracture history. So I think it's a very well received point that's been, you know, discussed because of exactly what you mentioned, that whether this actually increases the risks of fracture.
And just as we're wrapping up, we still have two more questions, so I'll just say them back to back. One is from Michael Frank. He's saying, is it possible that the low density was related to the severe events that brought these kids to attention to the hospital? And Gretchen had a great comment about also the question about, you know, could this be related to decreased exercise in youths that's resulting in impacting the bone health?
Yes, so the first question, I think it's similar to what Sarah Stevens, sorry, I'm getting a lot of feedback, similar to what Sarah Stevens was describing, you know, being a large center that we may in general have children with more severe, you know, clinical status. So I think that it could be a consideration as well. And I know the decreased exercise is something, you know, because that's part of a therapy, but is very, you know, intricate, like how you're gonna suggest that to patients in this population. So I think it's certainly a consideration. I know prior EDS studies have, you know, evaluated for exercise and then found there wasn't a difference. So it could be leading to more of a impact as well.
Great, thank you. So appreciate your work, Jennifer. We'll move on to our next speaker, and this is going to be Jessica.
Thank you.
Thank you. So Jessica Boss is going to talk about vascular Ehlers-Danlos syndrome, a comprehensive natural history study in the Dutch patient cohort.
Okay, and I'm going to pause the recording for this one as requested by Jessica. So let me just do that.
She's going to present on aortic involvement in vascular Ehlers-Danlos syndrome, a retrospective multi-centric cohort. Thank you, Anne. That was really great. While we're waiting for questions, I did have a question about the distribution of the aortic pathology and what part of the aortas, and was that different between the genotypes?
Sorry, can you repeat the question?
Sure, I was going to say I really enjoyed your talk, and then my question was, where in the aorta was the pathology located? Did you notice any differences between the genotypes and the expression of the aortic pathology?
I don't remember exactly the localization according to the genotype. 50% of patients in the 44 patients have a lesion in abdominal aorta. I can check. Perhaps Salma could help me to answer the question.
No, it was not abdominal aortic lesions. It was mostly type A, so ascending aorta lesions, and 50% dissections and 50% aneurysms.
Great, thank you. Do we have any other questions from the group?
If this is Peter, if you looked at the people who died who had the dominant negative mutations, did they die predominantly from aortic events? So you've lost them at the younger ages?
Yes, if I remember well, all deaths were related to aortic rupture.
So they get aortic events, but they're not in the cohort that you measured because they had died. Is that?
No, they were in this cohort. In this, in all these patients. So it's the retrospective cohort. So there were patients who are already dead, but we had the information, so they were included, and we looked at their arterial history, and they had MSA lesions and aortic lesions, for example, and they died from aortic rupture.
Hal also had a comment.
Yeah, this sounds very reminiscent of the observation in Marfan syndrome that haploinsufficient mutations seem to be associated with more aortic events, or a higher risk of type B dissections and other events. But I think the underlying driver of that may also relate, at least in part, to a selection against the kids with the severe dominant negative mutations, or kids and young adults who are, removed from consideration. So you're simply seeing enrichment for events that were already evident in the kids, in the young people with the severe dominant negative mutations at an older age. I'm sorry, at a younger age. So this sounds very reminiscent to that that story.
Yes, thank you for this very interesting and great talk. Two questions, very short. Do you think it was a systematic evaluation of the arterial tree or arterial event-driven imaging? And second question is, for some variants that bioinformatics do not predict haploinsufficiency. Sometimes we have fibroblast culture to look at haploinsufficiency. So did you have access to fibroblast culture for some patients for variants that was not well characterized?
Okay, so for the first question, people, when they come to, when we recognize that they have vascular EDS, we screen them independent of if or not they've had arterial events. So we definitely perform the scan from head to pelvis, and then even the popliteals we evaluate for those as well. Obviously some people come to attention because of arterial events. The fibroblast cultures, Dr. Byers is here and he does fibroblast cultures on people. So if that has been done, we do have access to that information. And I think it's really important to have this information, particularly in people like this person who had this large aneurysm, because, talking to the surgeon who operated on him at the time, his comments were like the tissue was normal, did not handle any differencing, and he was disbelieving the patient who told him, no, I really do have vascular EDS. This is my diagnosis. So I think that that's going to be very relevant. I've always said that I think that people with haploinsufficiency, I think we're operating on them as vascular surgeons, and we just don't realize that this is what we're seeing because their phenotype is generally mild. Peter, do you want to comment about fibroblast cultures?
Ulrika, do you want to talk about it? You've done most of the work about it. Ulrika,
I had to unmute myself. I'm a little slow. I'm not sure what the question about fibroblast culture is, because at the protein level, you know that better than me because you were my teacher from the beginning. It's hard to see sometimes. Some show up as decreased amounts, others don't. So is the question maybe about intronic variants that lead to abnormal splicing? Maybe I don't quite understand the question about fibroblast cultures. What's the goal is of looking at them? Peter, did you understand it?
So Tristan, were you asking whether all the ones that have predictive nulls are looked at, or whether they're, I think you asked a little bit about whether the ones that are uncertain in their actions, about whether they do. So Ulrika has looked at a set of those, and some do, some don't. Also
of significant unknown significance sometimes.
Yeah.
If you go to the fibroblast culture, you will see, for example, with qPCR, you can see a 50% amount of expression of the mRNA.
In some, in many not. The other thing to be aware of is that splice site mutations are not all or nothing. That is, they don't always skip. They don't always give you the use of cryptic sites with frame shifts. And one of the things that's striking about that is that there are mixed outcomes. And some of them are very striking. That there may be certainly more than one, sometimes more than two outcomes for these things. And so identifying the actual phenotypes are sometimes, or the molecular phenotypes is sometimes a little bit difficult.
Peter, do you know, are there individual determinants of the outcome of a splice site mutation, like expression of SR proteins, or have you seen individual variation in that for a given mutation?
Ulrika, do you think that, so in the intron plus 20, plus 1G to A, that has a lot of variance in it. And do you remember whether there's variation in what happens with those?
You mean the intron 24 one?
No, we have intron, isn't it intron 20?
I have to admit that I'm not understanding the question very well.
Yeah. That's the one that has.
Oh, the intron 20. Yeah, the intron 20 has multiple outcomes. Yes. And so, what is your question?
The question is, do some people have more of one outcome, and other people with the same mutation have more of another outcome?
I mean, the intron 20 mutation had always the same outcome in the 5 individuals we looked at. So I can only speak for an N of 5.
Okay.
I mean, there certainly are modifiers that affect splice outcome. Sally Camper from Michigan had done work on one of the neurologic genes that had shown that the modifier was actually something that modified the splicing efficiency. So I think that we would expect there to be. It's just that the quantitation that we have is not probably enough to be able to see subtle differences.
I mean, I can only say that the type of abnormal product was the same in those 5 patients, but is the quantity exactly the same? I don't know. We've never done additional studies beyond our polyacrylamide gel electrophoresis and sequencing of the abnormal products. So we've never gone beyond that analysis.
Shireen, can I ask you a question?
Absolutely.
So when I see images like the ones you showed or others in other conditions, the question that comes to mind is, why do aneurysms happen where they happen when they happen? And why is it a biased distribution rather than a random distribution if the whole equation is a mechanically weak blood vessel that's acted upon by stress? So, you know, I think that there are determinants of that. I bet that they don't relate to global vascular integrity, but you know, we're exploring some hypotheses related to embryonic origin. But what you showed that really doesn't match with that. Do you think that there are? Do you have any sense of what the predisposing events are that dictate where they happen and when they happen?
I mean, I'm beginning to sort of try to understand this, because when you read, without looking at these images, you know, when somebody says abdominal aortic aneurysm, you have a certain vision of what that looks like. But in reality, in this population, it looks very different than what we're taught as abdominal aortic aneurysms. And what's interesting is this particular isolated abdominal aortic dissection with aneurysms, that is very unique to vascular EDS. I mean, we looked at out of 1,000 people with aortic dissections, only 80 had this isolated abdominal aortic dissection. And the majority of those with isolated abdominal aortic dissection had a genetic condition. So it is interesting from that perspective too. Like, it's not your normal aneurysm either. It's this dissection and then with aneurysmal degeneration that is limited to the aorta. So it's a different phenotype than what we think of abdominal aortic aneurysms. And I don't know why it happens there. Really quick, Xavier, I don't know the numbers yet. I mean, there's some that have had repairs both open and endovascular. Most were, you know, are being followed for small aneurysms. Elizabeth, you had a really good comment about EHR. Elizabeth still there? So the comment about the EHR is we're going to actually pilot this with the Canadian cohort and see if we can access their records through Epic that way. And then if that works, then we can look at other potential ways of collaborating. But I think it's very powerful to have direct access to the records rather than abstracted data. And then we abstract the data in a uniform manner, and then the data sets will be standardized. So that's just something we're interested in doing as well.
Shireen, does any of the preliminary data information speak towards updating thoughts and surveillance?
I have always been biased towards saying I think surveillance makes a difference, because you can detect these aneurysms and you can do something about them. I do want to, you know, once we finish analyzing the data, I want to challenge the notion about surveillance not making a difference. And also, really, we need to look into how many people truly rupture with normal size arteries versus, you know, they've had a preceding aneurysm. It may be that they have small aneurysms that rupture earlier than what you would think of as the general population, but you do see quite a bit of pathology.
Sure, thank you.
Right, so the last talk in this—
Shireen, sorry, can I just ask one small question? I'm sorry. I just wanted to ask you about medical therapy. Do you have any, do you collect types of drugs these patients get, meds? Because when you see the images you've shown us, you think that there's some kind of emergency to know what how these people are being treated, if they are, and I think that would be very important, critical, to see what's happening and how to improve things.
Absolutely. And so again, the whole idea of having access to the full record is we can go back to the episode specifically and see what they were on before or not. So that's going to be really helpful. The other part of for the abdominal, for this aortic, those two projects, the other thing, because I know a lot of the surgeons who actually did the operations, you know, like obviously I know my people, but I also know the other surgeons in the US. So my plan is to call them directly and also discuss those cases with them, whether the diagnosis was known or unknown or what they did differently around that time.
Thanks.
Thank you. That was great. Was somebody going to answer? Is there somebody from her group present to answer some questions?
Yes, we can do that. This is Fleur.
Perfect. Well, then the virtual floor is open for questions.
Is it the virtual floor or the virtual Fleur?
No, it's the real Fleur. It's the virtual floor.
Okay, I'll just make a comment then, not a question. I think it's really interesting. I mean, we've had a handful of patients who've had reversal and have done extremely well. And I do think there's some phenotype correlation to that. You know, and I also think it depends on what the circumstances were at the time of resection. So certainly if there was a lot of inflammation at the time of the original operation, and that probably would make it a lot harder to argue towards reversal. But I'd love to hear other people's experiences, because that's always like the $1 million question when it happens.
Yeah, in our French experience, we've had a series of 46 colonic perforations, and there was a reperforation in almost 50% of patients following Hartmann's procedure and reversal. So there's a high risk of reperforation, but we generally do favor how do you say, the retrieval of the stoma for patients. And sometimes in some patients, we would recommend or discuss a subtotal colectomy to reduce the risk of reperforation, but that's another discussion.
So Michael, just so I understand you, you say you do prefer reversal or you do not prefer reversal?
Yeah, we usually try to do reversal. We, since the patients are young, predominantly males, they usually have a hard time living with a stoma, and of course it's obviously understandable. So we usually try to reverse them every time we can. Of course, the patients will participate to the decision, and if he doesn't want to, we don't. But yeah, usually we try to have that option always open.
In our experience is that I'm not sure that I've had anybody say, yippee, I really like this. That for practical purposes, almost everybody who has had a colostomy is asking for reversal. And it's certainly, in the last few weeks, we've had several inquiries about whether to do it, not to do it, and things of that sort. And I don't remember the exact numbers out of the group that we had, but we had, you know, a significant number close to what I think Michael had, but had surgery, had operations. There were some that had recurrences, most not, interestingly, not in the sigmoid. Some were at the analysis site, but it has been generally more successful than one might anticipate. And it's certainly, from the point of view of the patient, is a successful operation, usually, even with some complications along the way.
Are there any exclusion criteria for reversal that people apply?
I think the presence of ongoing inflammation and infection in the region would be a real problem. Anything that really makes the tissue just absolutely unable to be put back together.
I mean,
maybe also, I'm sorry, Shireen. Sorry.
Oh, sorry. Go ahead. Go ahead, Michael.
I was just wanted to say also maybe an exclusion criteria might be an exceptional colonic fragility that has been constated by the surgeon while he's operating. In this case, maybe would be an indication for subtotal colectomy or another surgical technique alternative to this one. That's yeah, with inflammation and exceptional fragility would be the two exclusion criteria, I think, that I know of. At least.
Yeah, I agree with that for sure. All right,
There's a very interesting thing, and I don't know, it fits to some extent in with the question that Hal was asking about the arterial walls as well. And that is that there seems to be areas in the, well, first of all, the large proportion of initial bowel ruptures occur in the sigmoid colon. And the sigmoid colon has, is vascularized both from the top and the bottom, and I don't know whether the areas of rupture occur, you know, at the, in the plane in between or what. But one of the things that was striking in looking at some of the histologic things is that the muscular wall of the bowel seems to be limited, and in fact some areas are missing. And it makes you think that there, you know, is that a feature of other areas, that the vasculature has the same kind of thing or may have the same kind of thing, and that these are developmental abnormalities that occur, and so they, you know, they don't necessarily crop up in terms of mechanical properties of the tissues if you measure them, but they clearly have a biological effect because of that there's something that's going on there, and the signaling in the areas may be different. You're trying to connect the signaling to the events, whether that's something that's happening. That here are developmental issues that are occurring that are in the context of this gene, and it's sort of, I can't fit it together, but it makes me wonder whether that's an issue or those are issues.
In Loeys-Dietz syndrome, aneurysms occur almost invariably at sites where embryonic smooth muscle cells of different embryonic origin interface. And I was looking at Shireen's pictures, trying to see if this was obeying any of the rules that we know. For example, a protection of the proximal iliacs, but not more distal iliacs. And to my knowledge, for example, that does not represent a transition in embryonic origin. So if something like that is going on there is an embryonic predisposition or some other anatomic predisposition. I don't think it's been defined, but it's a great question.
Well, Hal, just to add to the complexity of this, the common iliac arteries, what I have seen, tend to be predisposed to the bell-bottom aneurysms, less so dissections, but then the dissections occur in normal-sized external iliac arteries, and then subsequently the external iliac arteries will become aneurysmal. So it's a very interesting different phenotype between the common iliac and the external iliac, and I don't know why that is either, but it's I've seen it now repetitively on these images and in the patients that I see.
Do you think these are primary dilations or secondary to dissections? Because
so the common iliac is usually primary dilation in that bell-bottom appearance, while the external iliac is primarily dissection first, then subsequent aneurysmal degeneration. So it's like opposite. The two are opposite.
I think one of the things that's emerging from these sorts of things is, I think that the idea that ruptures and things occur in entirely normal vessels is going to have to be very strongly reconsidered. And I think that some of those data arose from the time when people did arteriography, stuck a catheter up, injected under very high pressure, and then in local regions or in regions that were somewhere near there, ended up having aneurysms and sometimes ruptures or dissections. But I think more and more, and I suspect you're seeing it with surveillance, that you're seeing aneurysms develop, and that the events don't usually occur in absolutely normal looking vessels. I may be wrong, and that may be part of it. And it reminds me also of this whole business about, you know, making the diagnosis on the basis of the criteria for diagnosis, and many people don't make them. And when the paper with Francisca was written, we tried very hard to say, look, those characteristics like facial features and other kinds of things are really a way to go towards the definitive diagnosis. And the definitive diagnosis for this condition is actually genetic testing. And it's part of the pathway as opposed to, I think the idea of diagnostic features, you know, the major and minor criteria derive from times when we had no molecular confirmation of the diagnosis. And I think that this has really changed.
I mean, a phenomenon we can attest to in the mouse model is, you know, when we sacrifice mice and look at their aortas, it tends to be a binary outcome. There's two, there are some exceptions, but in general, a mouse is either fine or dead. So you don't see aneurysms when you just take a large number of mice at a given age and dissect them. The aortas look fine, but then the next day, some proportion of them are going to die from rupture. So I really do believe, at least from the animal model work, that a normal appearing vessel is vulnerable.
So Michael, you have, I mean, I think that one of the striking things about the studies that were done in Paris have to do with the very high frequency of cervical dissections. They're not always the places where things go very bad, but those are frequent. And I'm surprised at the frequency with which we do see abnormalities in vessels in people with vascular EDS who have been screened.
Yeah, we have a very large number of carotid and vertebral artery dissections. What is extremely surprising is that we have a very low number of strokes and TIA. That's for neurologists. That would be very. It's always surprising them that we don't have ischemia, and probably it's because the artery has some sort of elasticity. When it dissects, it will hardly ever occlude, and the blood flow would still be maintained. That is probably one explanation about this high frequency, and no ischemia associated with it.
What's also interesting is that they heal. There's evidence that some of these people, when you look at them in subsequent imaging, they've healed their dissection. So where the artery looks normal. So I think that's also, interesting in terms of how you think about this.
Yeah, we have noticed that the radial and ulnar arteries, when they dissect, they almost always tend to heal, and you don't have any dilation, nothing. If you wouldn't have known or have an imaging of it, you wouldn't have known that there was a dissection. If you take leg arteries, you usually would expect to have a dilation following the initial dissection. So it depends very much where you are. But on the antebrachial arteries, they almost always heal, and you never see that in any patient. It's very strange.
So just for time interest, I am going to pass the virtual mic to Tony and Peter, and I'll leave it up to them, because this is truly great discussion, and this is the kind of discussion that I'd love to hear about, particularly in terms of thinking about the arteries. But I will pass the virtual mic.